All right, let's jump right in. Today we're cracking the case on something that millions of people deal with, but is so often misunderstood: asthma. It's way more than just a simple wheeze, and in this explainer, we're going to get to the bottom of it.
So, what's the deal? Why is asthma so tricky to pin down? Why do so many of us struggle to get a clear picture of what's really happening inside our own lungs? Well, that's the central mystery we're investigating today.
The reason is pretty simple. Asthma is a master of disguise. Its defining feature is variability. The symptoms can pop up and disappear, they can change from mild to severe, and sometimes they hide behind something as innocent as a nagging cough.
But hey, don't you worry. Over the next 5 minutes, we're going to crack this case wide open. We'll investigate the crime scene deep inside your airways, we'll uncover the key evidence for a diagnosis, and then we'll reveal the modern-day playbook that puts you back in the driver's seat.
Okay, let's get into it. The very first piece of the puzzle, the thing that really gets to the heart of what asthma is, all comes down to one single, crucial idea. And here's the key, the absolute #1 clue, the word variable. See, asthma isn't a constant thing. It's not like you're always short of breath. It's a long-term inflammation that causes symptoms and breathing problems that change, that fluctuate. That variability, that's its signature.
And this chart, it lays it out perfectly. Asthma symptoms are episodic. They come and go. They flare up with triggers and, importantly, they get better with the right treatment. This is the total opposite of a condition where the symptoms are just there, always the same day in and day out. Bottom line, if it's not changing, if it's not variable, you're probably looking at the wrong suspect.
Okay, so what's actually going on in there to cause all this change? Let's zoom in on the crime scene itself, deep inside the airways, to see how this whole thing kicks off.
It all starts with the trigger. Could be dust, pollen, anything really. Your immune system just goes into overdrive, setting off this chain reaction of inflammation. Your airways swell up, they start pumping out way too much mucus, and the tiny muscles wrapped around them squeeze tight. And that whole chain reaction, that's why we say asthma isn't just a muscle problem. At its core, it's an inflammation problem.
So you've got this whole inflammatory crime scene happening. How do doctors actually gather the hard evidence, the proof they need to officially close the case and say, yep, this is asthma?
Check this out. This number right here, this is the smoking gun. It's the diagnostic fingerprint. When you do a breathing test, a spirometry test, the doctor is looking for this. After you take a puff from a reliever inhaler, does your lung function jump up by at least 12% and by 200 milliliters? If it does, that's the objective proof of that classic asthma variability we've been talking about.
Now, spirometry is a big one, but it's not the only tool in the detective's kit. You can track things at home with a peak flow meter. If tests are normal but suspicion is high, a bronchial challenge test can confirm if your airways are extra sensitive. There are even biomarkers that can add more supporting evidence. The main takeaway here is that a real diagnosis needs both your story, your symptoms, and this kind of objective evidence.
Okay, now for my favorite part, the disguises. Because asthma doesn't always show up looking like asthma. It has a few classic imposters that can throw anyone off the trail.
First, you've got the cough variant imposter. With this one, the only clue, the only symptom is a nagging, dry cough that just won't quit, and it's often way worse at night. Since there's no wheezing, it gets missed all the time. But make no mistake, it's asthma.
Next up, the workplace saboteur. This is what we call occupational asthma. The dead giveaway here is the timing. Your symptoms are a problem all week at work, but then, like magic, they get better on the weekend or totally disappear when you're on vacation. That pattern is everything.
And finally, we have the overlap offender. This happens when someone has features of both asthma and another lung condition called COPD. They've got the constant airway issues from COPD, but also that classic up and down variability of asthma. And these folks need a special kind of game plan, one that, and this is non-negotiable, always includes an anti-inflammatory.
All right, we've identified the culprit, we know its disguises. So what's the game plan? Let's get into the modern strategy, the playbook for getting this thing under control for good.
The way we think about this has done a complete 180. The old way was all about reacting. You wait for symptoms to show up, then you grab your blue rescue inhaler. The new way? It's proactive. It's about getting ahead of the problem by treating that underlying inflammation with every single puff, not just chasing symptoms after they start.
Which brings us to the #1 golden rule of modern asthma care. You ready for it?
Any treatment for asthma must include an anti-inflammatory. We call it an inhaled corticosteroid, or ICS. Just using a reliever to open your airways without dealing with the fire of inflammation, that's not just a bad idea, it's actually dangerous.
So, the modern playbook is actually pretty straightforward. It's all about stepping up the treatment when you need to. For mild symptoms, you just use a combination anti-inflammatory reliever when you need it. If you need it more often, you move to the next step and use that exact same inhaler every day for maintenance and for rescue. It's a genius strategy called MART. From there, your doctor can increase the dose or even add on specialist therapies. It's a clear, safe ladder of care.
And look, all this information isn't just for your doctor. The whole point is to put you in the driver's seat, to empower you to be the lead detective in your own health story.
So here it is, your personal control checklist. First off, your inhaler technique. It's gotta be perfect. Seriously, ask your pharmacist for a demo. Then, get to know your triggers and clear them out. Take care of other issues like acid reflux that can make asthma worse. Work with your doctor to create a written action plan. And never ever forget that safety rule. No long-acting bronchodilators without that anti-inflammatory ICS right there beside it.
So there you have it. We've unmasked the disguises, we've followed the clues, and we've laid out the modern strategy. The mystery is solved. So the only question left is, with this playbook in your hands, are you ready to take control?